Hello, I'm Dr. Reginald Bell, and I'm here to discuss our recent study, Laparoscopic magnetic sphincter augmentation versus double-dose proton pump inhibitors for management of moderate to severe regurgitation and GERD, a randomized controlled trial. You know, over the past few years, there have been a few elements in the landscape of GERD that have changed. Patients are becoming increasingly wary of taking acid-suppressive medication chronically. Practitioners are recognizing that lifestyle and acid-suppressive medication don't control symptoms as well as has been touted. And specific GERD symptoms are being more closely associated with differing etiologies. And also newer, less invasive technologies have promised control of reflux with fewer side effects than laparoscopic Nissen. If we put these various elements together, we can ask, is there a scenario in which minimally invasive anti-reflux procedures really excel in controlling symptoms and might be preferable to acid-suppressive medication? As we become more aware of the limitations of proton pump inhibitor therapy to adequately alleviate symptoms in GERD, we realize that sometimes the symptoms are not due to GERD. However, sometimes persistent symptoms are due to GERD, and regurgitation, which reflects a failure of the anti-reflux barrier, is one such symptom that frequently responds poorly to acid-suppressive therapy. Regurgitation, that sense of stomach juice flowing up into the esophagus, is a symptom that plays second fiddle to heartburn and is often overlooked in discussing GERD symptoms. Yet regurgitation severe enough to impact quality of life persists in roughly 15% of patients whose heartburn is controlled on proton pump inhibitor therapy. And when regurgitation does persist as a symptom, practitioners often increase or change the dosing of a proton pump inhibitor, often with little improvement. This results in frustration on the part of patients and practitioners alike. To reiterate, regurgitation reflects a failure of the anti-reflux barrier, and acid suppression, which only changes the acidity of the refluxate, doesn't address this failed anti-reflux barrier. New, less invasive methods of restoring the anti-reflux barrier in GERD patients have caught the attention of many gastroenterologists and surgeons, with the expectation that they can deliver restoration of function with fewer side effects. Laparoscopic placement of a magnetic device to mechanically augment the lower esophageal sphincter. The LINX device is one of these newer technologies. And so we conducted a prospective randomized controlled trial in patients with regurgitant symptoms that persisted despite once-daily PPI therapy. 150 patients with moderate to severe regurgitation on 20 milligrams of omeprazole daily, the FDA-recommended dosing, were randomized 2-to-1 to either 20 milligrams of omeprazole BID or to laparoscopic implantation of the LINX magnetic sphincter augmentation system. Safety, symptom resolution, and objective reflux parameters were assessed in follow-up. Transient dysphagia, typically mild, was reported in about 26% of LINX patients. Capsular formation or scarring around any implanted device is a normal physiologic event, and postoperative dysphagia is an anticipated event after magnetic sphincter augmentation implantation. However, with appropriate postoperative care, which we detailed in the manuscript, long-term dysphagia, 4% in this study, is uncommon, and in this study did not result in any device removals. Regarding relief of regurgitation, using a 6-month endpoint, we found that 89% of patients who underwent the LINX surgery reported resolution of moderate to severe regurgitation, compared to only 10% of the twice-daily omeprazole group. We measured this by a couple of different standardized questionnaires and came up with similar dramatic differences in outcome. We also performed 24-hour impedance pH testing at 6 months, off PPIs in the LINX group and on PPIs in the BID PPI group. In the LINX group, a normal number of reflux events was observed in 91% of patients. Normal esophageal acid exposure was observed in 89%. So it's not surprising that 89% of the surgically treated group reported relief of their moderate to severe regurgitation. In the twice-daily omeprazole group, 24-hour impedance pH testing at 6 months on twice-daily PPIs demonstrated an excessive number of reflux episodes in 42%, and persistent excess esophageal acid exposure in 26%. And even many patients with normal impedance pH testing while on BID PPI therapy reported ongoing regurgitation, which was very uncommon and different than the LINX-treated group. We also used the GERD HRQL. It asked 6 questions about heartburn, 2 questions on dysphagia, but none on regurgitation. It's a quality of life survey used in many surgical studies, and we wanted it as a comparator to see if the surgical arm outcomes were consistent with other LINX studies. And what we found was that LINX resulted in a dramatic improvement in the GERD HRQL in 81% of patients. Again, recall 89% of LINX-treated patients demonstrated normal esophageal acid exposure. However, only 8% of patients in the BID PPI group reported improvement in the GERD HRQL, despite 74% having normal esophageal acid exposure. This is very interesting because it's often touted that PPI-resistant symptoms such as heartburn are not due to GERD. However, if we look at both arms of this study, it suggests that medically refractory heartburn, at least when coexistent with regurgitation, can and likely is due to GERD. An improvement of medically refractory heartburn can be anticipated with surgical treatment in this group. And so what does this mean in the grander scheme of things? Well, I think we've identified a group of GERD patients, those with moderate to severe regurgitation despite daily PPI therapy, who will respond excellently to an anti-reflux procedure, in this case, laparoscopic placement of the LINX MSA device. Additionally, we found that doubling the dose of PPIs results in a very low 10% response rate in patients with moderate to severe regurgitation. And so we concluded that magnetic sphincter augmentation with LINX provides significantly better symptomatic and objective control in reflux in patients who have moderate to severe regurgitation when compared to twice-daily PPI therapy. And understanding the vast difference in response rates between increased dose of medication and magnetic sphincter augmentation we found in this study, we concluded that GERD patients whose regurgitation is inadequately controlled after initial dosing of acid suppressive medication should be considered for minimally invasive surgical treatment with MSA, with anticipation of excellent outcomes.